Tot zover onze posterpitches. Wij hopen dat u genoten heeft van de variatie. En ja, dat is ook een hele mooie manier om toch weer nog heel veel onderwerpen weer even kort aan bod te brengen. Dus bij deze. Maar dan gaan we nu snel verder naar onze gast uit Amerika. Melinda Cavanaugh. I hope she's in the air.
Hello.
Hi.
Hi.
We're very pleased to have you here. As our esteemed guest for today. Yes, you are. I'll introduce you. In your research, you focus a lot on children and teens of patients with neurological disorders like ALS. And I understand that the results of your study were used to develop educational and caregiving information. And I'm very interested how that process has gone. And well, it's a very important study we're also having in Holland. You are also participating in that study. So, well, I've often said it today, it's a very important topic which we think we don't pay enough attention to, and you're going to change that, I hope. So,
goodness,
thank you.
I hope so. Thank you all so much. Thank you for that lovely introduction. That was very kind of you. I am incredibly honored to be here. Be with you. I'm here in my living room, but I am just so very grateful to be with you all. I'm sorry that we aren't all here in person, but what a wonderful opportunity to be able to do it via video. So yes, thank you. That was a lovely introduction. I'll get started on my presentation. So yes, my name is Melinda Cavanaugh. I'm an associate professor in social work at the University of Wisconsin in Milwaukee on a very dreary gray day here. So it's a lovely day to just sit and chat with you all about my work. As you can see, I have been a clinical social worker for almost 20 years now. My primary area of clinical practice was in neurology, which is really where my interest in this topic took root. So I primarily served in a clinic for movement disorders. So I spent a lot of time with Huntington's disease and Parkinson's disease, but would occasionally be pulled into the ALS clinic or the Alzheimer's disease clinic. And from there, I got to meet many, many families, the majority of whom had children in the family. And at that time, there were no services or supports for these kids. And they were doing all kinds of care tasks. They were isolated. They didn't have friends. So I really got deeply involved in a lot of the community organizations, a lot of the disease-based organizations. And upon going back to get my PhD, that's really the area that I focused on, not only in getting my PhD, but now in all these years later as an associate professor. I continue to focus on neurological disorders, given the extreme complexity of living with them. A large majority of our neurological disorders just don't receive the same level of treatment funding, of attention. And so when that trickles down to the children and youth in the families, they are exceptionally isolated and very, very vulnerable. And so my research is extensively built on my clinical practice in all the years of meeting all the families that I did, working in homes and nursing homes and hospitals. So I am extraordinarily grateful, and I do have a slide at the end, but I always want to start with thanking the families because these are our heroes, and particularly the children in their families. So it's a topic I'm very passionate about, and I will talk about some of the interventions that I have been incredibly fortunate to be able to develop. And thank you so much again. And I'm thrilled to be working with both Dr. Breland and Marianne on a couple of projects. So thank you so much. This is just a brief quote from one of the youth in an interview that I did many years ago. And I like to start any project or any presentation with the words of the youth themselves, because again, I can't point out enough. And in the introduction, it was so well said. There is so much more to be done with the youth in these families. And so in interviewing a young woman, asking, what are the things that you need? How can we do to help you? This is a direct quote where, she says, it's nice that people ask about my mom, but it would really be nice if someone asked about me and like how I was doing. So to me, that was incredibly profound and a way to really continue focusing my work on the children and youth. So when we talk really broadly about how children are affected in families with illness, regardless of the disease state, we know overwhelmingly that they are isolated from peers because a lot of their peers do not have an ill family member. There are very few targeted supports. And when I say targeted supports, I mean supports from organizations like here in the US, the ALS Association, or a cancer organization, really targeted programs that are based in disease states and that really help children and youth. And what we see in these families, because they're isolated from their peers, because there are very few ways to support them, that these families really can experience a tremendous amount of stress and conflict. And in some of my earlier work in Huntington's disease, the levels of family stress and parent-child conflict were significantly higher than in any normative population. So we do know that that is going on in these families. But one thing that is very much going on and receives very little attention is this role of caregiving. So children and youth who provide care to a family member, and they're referred to a variety of different ways across the world. But one of the more common ways to refer them is as a young carer. So I'm going to spend a little bit of time talking about young carers right now. So who is a young carer? And primarily when we think about a young carer or a child or a youth or a young caregiver, they're typically children under the age of 19 or 20, depending on the context in which they're living. Children can be as young as 5 or 6 and provide care. And these are people who aren't just doing things like household chores, dishes, laundry. These are children and youth who are actively engaged in caregiving. So when I say actively engaged in caregiving, this is data from a national survey that I did several years ago. And looking at all of the research projects that have done in the US, which sadly is very, very few. What we know is that youth are deeply involved in medication administration. These are children who are administering medication pills. They're also injecting medication. Children are very involved in bathing and toileting. So this particularly is something of great importance in this area, because when we talk about the need for peers and peer support, when a child is giving their parent a bath, that's not something that they tend to share with their other friends. So that context of providing care, and particularly providing that type of care, increases their isolation from their other peers. We also see that children and youth are deeply involved in lifting and transferring. And if you think about the height differential, and I'll talk about this in a moment in one of the interventions we've developed, but it's very, very difficult for a young child who comes up to here and the adult has quite a different height differential to figure out how's the best way to lift and transfer someone. Children are also involved in preparing and feeding food to their parents. One of the first interactions I had with a young caregiver almost 20 years ago now was with a young child who was telling me how they were now responsible for the feeding tube for their parent. They showed me how they cleaned it and disinfected it, how much of the liquid to put in it, how to hold it up at a certain height so it went down in the normal way. this is extraordinary tasks that children are deeply involved in. And the last, but absolutely not least, is that children are what I term waiting and watching. So they're on alert. So, sometimes people say, oh, well, they're just kind of home with their parent and they can be doing homework or whatever. But the truth is they're not, because they're on alert. They're waiting for something to happen. They're waiting for that parent or grandparent to say they need something. They need help with some other task. And so it's hard for them to divide their time. So this high alert of watching and waiting, we're just now starting to understand the physiological impacts on the child and youth. And we'll talk about that in a moment as well. So when we talk about children and youth who are caregivers or young carers, one of the biggest questions I have been asking youth over the years is, what do you need? How can we help you, right? So as a social worker, that's immediately where I go, right? What kinds of programs can we develop? What kinds of services and supports can be engaged and delivered to you? And this is some data from some earlier research that I did across Huntington's disease and ALS, and looking at the kinds of support that children are needing is really powerful, because what it speaks to is their deep engagement in caregiving. So they certainly are looking for that emotional piece. Not only friends who are going to get it, they want people to understand them and be okay with the role that they're doing as a caregiver. They want to be normal, they want to be cared about, but they also want help, right? So this piece about the instrumental support has really been the baseline, if you will, for a lot of the research that I'm continuing to do, because this is where the children and youth first said, I need information about the disease. I need someone to actually help me do it and teach me how to do it. And then I want someone else to step in on occasion and actually show that my parent is worthy of someone else's time. So these kids are incredibly insightful, and they've laid the groundwork for, these are the things that we need to do to help them move forward. So this is data that was published by a group of folks in the UK. So the UK has really been at the forefront of young carer broadly, writ large, for many, many years. And as you can see, the moderate to significant impact on all of these areas is quite profound. Everything from leisure activities to financial circumstances. We do know that children and youth who are caregivers, often that type of care is reflected in working outside the home at a very young age because of the health issue and disability of the parent, sometimes both parents in the home, to the impacts to their physical health and their mental health. Quite frankly, these do not get enough attention, because a lot of times when we think about children, we think about them in the context of their resilience, which is true. Children can be incredibly resilient in the face of extraordinary circumstances. That said, that does not mean that these kinds of stressful, concerning tasks aren't also impacting their own physical health and well-being and their mental health and well-being. So I think that this, again, kind of broadly is very important data, because it shows us as practitioners, right? So I'm a professor, I'm a research professor, but I still always think halfway with my social work hat on. And I always think, what is that practice implication? And just in this one slide alone, there are so many practice implications that, excuse me, ooh, I got a little ahead of myself, that can be applied across settings and across countries. So that's kind of a very quick and broad perspective about young caregivers, again, writ large. Now I'm going to narrow it in and focus on young carers and ALS, because that's what we're all here for. But also that's where over the past 6 or 7 years, my research has really focused on children and youth in ALS. And I started doing work with the ALS Association almost 8 years ago now. And as I have been engaged with them and started to develop some of the programming and materials that I'll talk about, I have been so fortunate to get a lot of feedback from the parents. And this is profound in that earlier we heard the child say, or we read the child say, it would be nice if someone paid attention to me, right? This is the parent saying much the same thing, saying it's great that we're thinking about the patients, but really paying attention to the children, because ALS affects the whole family. And I underline that because that's really the gist of why I'm here today, and hopefully what I can share with you all. The majority of you here, likely this is nothing new, but just to reiterate that ALS is a disease of the family, because everybody really is affected. And so I set out, so this paper was published by Neurology at the beginning of the year of 2020, before the world fell apart. So, but this was the first data that I collected on ALS families. So we did 2 studies. We did a very small pilot study here in Wisconsin, where I live, trying to see, because no one had collected any data. We didn't know anything about children and families with ALS in the US, nothing. And so we did a small pilot study. And then from that, we did a larger national survey of families affected by ALS. So in both the national survey and the pilot study, we did almost 80 interviews with children and youth who are living in families with ALS. And I just highlight some of the data here because I wanted to point out some of the most oh, wow, really powerful and important, and again, practice implication data. So we do see that almost 50% of them are younger than 12. So that is a lot of children, young children, who are actively engaged in care for their family member. Now, this study was open to both parents and grandparents, given the often older age of onset with ALS. What we do know is that children are providing care often daily, many hours a day, and that a lot of the care really occurs in the evening and at night, disrupting their sleep, and which leads to one of the studies that I have been working on now, which is really looking at the impact of sleep, the impact of caregiving on sleep. So we also noticed that more than half of the youth had no training. No one had ever told them what to do. Now, as an adult, I was a caregiver for my grandmother. Now, this was close to 20 years ago, but I was an adult and I struggled with knowing what to do. So thinking about a 10-year-old, what that would be like. So that was also a really profound finding. And actually it had reflected a lot of my previous research in both Huntington's disease and Alzheimer's. And I put that on there because we're talking about families and ALS, but so much of this really crosses over a variety of disorders, particularly neurological disorders. So those of us who might work across other diseases, we can recognize that this is a shared experience, that it's not singular to ALS or Huntington's disease, that it really is the experience that children feel when they're providing care for a family member. I add this slide quickly because one of the things that we are really kind of grappling with is that there is not enough data across the world to really help us understand that experience of care, the experience of the families of ALS. So I've actually worked with my wonderful colleagues in South Africa for many years, and this was our first pilot study that we did. But again, children are doing care regardless of where they are. But that's why it's so wonderful to be able to collect data in kind of a low middle income country, collect data in the US, and now my absolute honor to work with you all in the Netherlands to collect the data here so that we can really make some broad comparisons, some similarities, and really make the case that ALS must be higher to the forefront, if you will, when we're talking about impacts on families and potential negative burdens and impacts on children and youth. So I put this up here briefly. I am more than happy at any time to expand more on the South African data. This is the first summer I have not been there in 6 years. So I'm very sad about that. But yes, I'd be happy to talk about that more. So this is, I think, an important slide. So this is caregiving tasks by age. So something that people ask me all the time, or they make an assumption, is that it's the oldest youth in the home who are more engaged in care. Now, obviously, it's different if there's only one child in the home, but if there are multiple children in the home, what we find is actually the age group where the most care is taking place is this kind of middle tween age, right? So those 13 to 15-year-olds. And if you think about it, you know, the older kids might be out working a job, or what frequently happens is they have access to a car and they can get away. They can get out, they can go do other things. The really young kids, if there's a middle-aged child in there, the younger kids aren't always tasked with all of the tasks. So what happens is the care tends to fall on this middle tween age group. And this is really important, particularly for interventions and around schools. So we'll talk about that in a moment, but schools are a critical piece for engaging these children, for providing support, for helping and making sure that they have respite from any sort of care burdens or care tasks. And this middle-aged group can be a very tough one because they're really coming into their own. They're starting to form their own identity, and they often can feel trapped in these care tasks. So it's a very important thing to recognize those age groups. We also see, and I put together some data from a couple of different studies, both in Huntington's and ALS, and you'll see, regardless of the disease, children are definitely, their school performance and attendance is affected. Most often, they are too worried to concentrate because these are kids who might have left the parent at home and hoping that they'll stay in their chair, in their bed, that they won't choke, that they won't try to get up or fall. And so they're thinking about this all day long in school. We also see that kids are absent from school because they are being called for care duties, and that they're missing school activities. And these are things that are after school sports. I have talked with many youth who would like to be involved in music, band, musical theater, or drama, and they're unable to because they are really needed at home. And one of the things that I have found in both my US and South African data, I don't have a slide on it, I'm realizing that right now, but the majority of parents rely on their child for care due to cost. So I think that's a very important conversation, but is very culturally and socially influenced, right, by where this family resides. You know, are they in a country that has more socialized medicine? Are they in a country like the US where we don't have socialized or a national healthcare plan? So that may or may not resonate across countries and cultures and societies and groups, but it's certainly something here in the US that we worry about because of the lack of ability to pay for home health or pay for healthcare. They're relying more on children to fill that gap. So one of the things that I said earlier was sleep and well-being, and this certainly came about from the data and from a lot of the qualitative work that I have been doing, where kids talk about having to get up in the middle of the night, where they talk about having to stay up really late or getting up really early to be that caregiving point person. And we certainly know that adults who are caregivers report quite a bit of sleep disruption that impacts their work, their cognitive functioning, their emotional ability to, perform and be a functioning adult in their family. In a brief study in the conducted by the Young Carers Trust in the UK, almost half of the young carers under the age of 18 are getting up in the night to provide care. So this is in the context of, we know children and youth need a lot of sleep, right? So adolescence tends to be that time where they just need the most sleep. And yet, as a caregiver, they're being drawn out of that sleep, and they're being required to sleep less, have a disrupted sleep. And so we do know that there's a lot of anecdotal evidence out there that their sleep is being disrupted. So in a research project I've been conducting with the Medical College of Wisconsin with two of our neurologists and a sleep expert out of California, we did a small pilot study just to see, can we get these kids? Can we measure this? And what we had them do is we had them wear the Actigraph device, a gene active device that they wore it for 5 straight days, 5 consecutive 24-hour periods. They also filled out a journal letting us know what kind of care they were doing, if they were getting up for care or if they were just getting up because they were disrupted. The non-caregivers obviously didn't fill out the caregiving portion of the journal, but they also let us know when they got up, why they got up, if they got up at all. And what we found in this very small study was that there was a significant difference between the caregivers and the non-caregivers, particularly in the rhythm strength. So the strength of their sleep. We also found that the robustness over their 24-hour periods was absolutely disrupted in the young caregiving population. But to note, when we compared the gene active data to the journal entries, this disruption was not purely due to them having to get up and provide care. A lot of the kids didn't actually get up and provide care during some of these 24-hour disruptive rhythms. They were just anxious and they were worried and they just weren't sleeping. So there are so many different practice implications here, not the least of which is respite for children and youth who are caregivers, emotional interventions, supportive interventions. This was a very small study and we're actually just starting, we did just receive funding to do a much larger study to where we're looking at 40 in each population, so 40 caregivers and 40 non-caregivers. And we're just about to start that study now. So hopefully we can build on it and supply even stronger data in this area. So one of the ways that I have been working with the ALS Association to try to think of, what are the things that we can take this data that we've collected and apply it to support programs, support interventions, education. And one of the biggest things that kids have said across all of my research is that they don't know enough about the disease. They feel isolated, so they don't really know that other kids are going through the same thing, and that they struggle with a lot of the big issues, particularly death and dying. So over the course of the years, I've written, we just completed the 5th book, which is a book on school personnel. So it's a book that provides lots of detail, lots of specifics about how to support, how to understand what they're going through, and what are some ways to really support and share those children who are living in families with ALS. But these are 3 books here. The book all the way on my right your left, I think, is a graphic novel, and that's for the youngest age of children. Then the middle one is for kind of that tween book, and that one is what we created was a kind of a you tell the story. So all of the people in these books are real. They're from my interviews, they're from my research, but this middle one allows those children to really kind of, well, what would you do in this situation? Because it really taps into their need to start developing their own identity. The book all the way to my far left is really for young adults. And these are kind of the older youth who often get even more ignored, if you will, because they're in high school, they're going on to university, maybe they're in relationships, maybe they're wanting to start a family of their own. And there's a real tension at times with how do I manage that with being a caregiver for a family member. And so these books they're all in English. The Real Kids, the graphic novel is actually being, it's translated now into French and German. The Swiss Association has completed that. So, but these are all available in English and, German and French through the Swiss Association. But if anybody is interested in getting copies of them, you can do that through the ALS Association in the US. But another thing I'm going to spend a little more time on, trying to be mindful of my time here, is this idea of skills, support, and guidance. And that has come up in all research projects that I've done, that children and youth don't know what they're doing, they don't have enough guidance, and they don't feel supported. So one of the things I really tried to dig into is, why are we interested in this, and why should this be so important, besides the kids saying we need this, right? And we know that when caregivers feel that they have some real skills and a skill-oriented training, it really helps with that piece about anxiety and depression, that mental health that I talked about earlier. They also develop a sense of confidence and self-efficacy, which is so critical with youth who are in those developmental stages of just trying to find out who they are and how they fit in the world, and what can we do as practitioners to help them build that confidence and skill. And last but not least, we really want to make sure that they're getting appropriate guidance so that they aren't physically harming themselves. Again, going back to that height differential with lifting and transferring, that's incredibly difficult and really ripe for injury if children or youth or adults, frankly, don't know what they're doing and aren't doing it correctly. So data from the ALS study, I asked children and youth, do you know what you're doing? How do you know what you're doing? Who's ever shared with you what to do? And when we're asked, how did they know what to do as far as the care they were provided? This is the kind of responses that they gave. They frequently just kind of watched and observed and then tried to mimic what they saw. They often said that they treat the person with ALS like a child, as if they were babysitting. So like, diapering and toileting. They often let the patient tell them what to do, which is difficult and concerning, because if you're living this experience, it's hard to be able to step outside yourself and say, this is how I need to be lifted in a way that doesn't hurt me or you. And my personal favorite is a fair number of you said, well, they just used common sense, which is entirely unclear what common sense is to a 10-year-old versus what common sense is to a 40-year-old. So what this data showed us was children and youth are deeply involved in care. They don't have the guidance, and they often don't have enough information to really make kind of logical or rational decisions, often due to their age. So this is something I've called Why Care. So it's youth caregiving. And again, this whole program was born out of all of the research. And what we have been working on for almost 6 years now is developing and honing and tweaking this day-long program that is multidisciplinary. So hearkening back to my years as a clinical social worker, I worked very closely with physical therapists and occupational therapists, speech language pathologists. And so that's part of my DNA, if you will, in that it's about that multidisciplinary team. And so approaching this caregiver skill and support program, it was critical that we do it in a multidisciplinary way. So this is, this screen has a lot going on, but we have 2 papers out discussing the development. So the kind of early feasibility tests where we made lots of mistakes and we tried to figure things out, all the way to 2 of our larger pilot studies. But really it involved meeting with the ALS multidisciplinary team and asking, what are the tasks that you get asked the most to teach? Then we went to the youth data and looked at the tasks that they were most often involved in. We put those together and we tested it out. And we started out with far too many tasks, and it was a day that was just intense. So over our tests, we have kind of honed in the amount of tasks that are taught for the youth each day. And they'll go through different modules. So it's a modular day. So apologies, I'm going to flip back and forth. So these are different modules here. So they will spend 45 minutes in a basic care module with the OTs and PTs, and they'll be learning things around transferring, helping to dress, even toileting. And, you know, interesting, the toileting issue, the people who had the biggest kind of concern, if you will, were the therapists. The youth walked in and said, oh, thank God, I have to, you know, I have to help my grandma go to the bathroom. And I just feel like I don't know what I'm doing. So I think that's a good lesson for us as professionals. Then they have a communication and feeding module. So those are largely delivered by our SLPs, but also OTs come in and help and talk about heavy weighted spoons, bowls that are heavy, that don't rock, talking about low tech communication, different feeding, different textures. So the kids get to mix different textures and say, this is thin, why is this helpful or not? This is thick, why is this helpful or not? Then they have a whole session on assistive devices. So this is something we found that children are very involved in these communication, eye gaze, respiratory BiPAP, but they're scared of them because they're always attached to the person with ALS. So if you take the person with ALS out and then they get to play with these devices, they feel much more comfortable and much more confident in understanding how they work and even doing some troubleshooting. And then lastly, woven throughout the whole day are support moments, we call them. It's not a huge module, it's here and there, it's scattered throughout, and that's facilitated by our social work staff. So you can see, going back to this slide, this is a picture of the food prep. So this is one of our, and we've actually tested this all over the US. So this one all the way to my far right, this picture under food prep and feeding, that was done in Massachusetts. So this is one of our speech language pathologists, and she's working with kids to understand different different spouts on glasses and cups. This one right here in the middle was done in Washington, DC under the eye gaze equipment. And this is an OT, and she is helping kids learn how to use the glasses that have the laser on them. This one right here, the power chair, this one was also done in Washington, DC. And this is where kids can kind of get a feel of, oh, this is what it's like to be in a power chair, you know? And it can be fun, but then they also can understand, oh, if there's a problem, you know, they're not going to fix it, but that they understand how to make it stop, how to make it move and whatnot. And then lastly, this respiratory equipment. And this one is the one that kids struggle with the most. They're the most concerned about because they feel like if they get anywhere near these machines, they're going to somehow kill their family member with ALS. And that's often the words they say. So being able to, like you see this phenomenal respiratory therapist, God, she's amazing, working one-on-one with these kids. This is what it feels like to have a cough assist. This is what it feels like to have a BiPAP. And this is, you know, if at the end of this cord isn't connected properly, then there's going to be some air hissing out the back. And so it helps the kids understand some small bit of troubleshooting. Again, they are not the fix-it people. They're not mandated to take care of all of this, but it gives them that peace of mind and that understanding of what they're going through. And so what we see is we actually did find some real solid, significant increases in confidence across different care tasks, particularly those communication systems, which is funny because a lot of people always say to me, oh, kids are all techie and they understand. But the truth is they've never really been able to work with them before. So this is some really important information, is that the kids are increasing their confidence in using and understanding these. They're also increasing their confidence in being able to do things like transferring, again, understanding how do I deal with that height differential, because it's a huge part of what these children do. I realize I'm running low on time. So this is a great response of the parents just thanking us and saying, you know what, he participated. And since he has participated, she's actually seen him be more confident in helping his dad. And that's really helped him kind of explore his confidence broadly. So it's a really wonderful thing when the parents can get involved and say, oh, wait a minute, I see a huge difference there. So speaking of parents, this is my last section. This is the first book that I wrote on families and ALS. And this came out of a lot of the data that we saw in the studies showing that parents really struggle with talking about ALS. They don't know what to say. They don't know when to say it. They feel like they're, you know, being overly intense, not intense enough. So in this book, and again, this is available if anybody wants it, it's in English, but you know, certainly available to be translated. What we know from the data is why parents really struggle to talk. And this is so important for us as practitioners and professionals. You may not be a social worker, you may not, you know, really interact with kids at all, but maybe you're a neurologist or maybe you're a physio and you're working with the person and you know that they have children and you have these conversations. It really helps to kind of understand where that parent is coming from. And in that national ALS study, this is really the primary things that parents said. They don't want their kids to have to think about ALS. They think they're too young. And they don't know what to say anyway, which is interesting because when you interview the kids, they're the ones who are saying, I think about it all the time. I don't know exactly what it is. And I wish my parents would tell me something. I wish they would just talk to me about it. So we see such a dichotomous experience between the parents and the children. And answering these difficult questions, you know, this is one slide. I could do an entire presentation on just talking with parents on how to talk to their youth. And one of the most important things is to have the person with ALS and their adult, what's going to make them feel comfortable? Like, how would you like to do that? And that can be actually kind of, where do you want to sit? You know, do you want to be outside? Do you want to be in the park? Do you want to be at home? You know, think about how and where it would make you feel comfortable. But one of the most critical things is being willing to have the difficult discussion, because children have access to the internet. They have access to their own imagination, which is often wildly beyond what the reality is, right? So helping families talk about what makes them feel uncomfortable helps the child feel comfortable to be honest with what they think is uncomfortable, right? So, you know, one of my family members that I've worked with for many years said, you know, when I lost the ability to use my arms, I talked with my child about how weird that felt and how awkward it was that they just kind of hung down by the side of my body. And that helped the child say, well, I've been wondering what that's like how, what can we do? And what does that mean? And so it really opened the door, but it required the parent to be in that difficult and awkward space, to let the child know that they could also be in that difficult and awkward space with them. And then answering honestly, and I know a lot of this is probably not any surprise to most of you on this call, but it's surprising how many families say, oh, it'll be fine, or he'll get over it, or this will just go away. And the truth is that it won't. And so, but kids know that. And so oftentimes kids have much more insight than adults give them kind of any credit for. So it's always okay to say, I don't have all the answers and we're going to figure this out as we go along, but this is tough. And I'm going to be honest with, I'm having a hard time with this. We're all having a hard time, but we're going to move forward with this. We're going to get help. We're going to get people to be a part of our lives, but not to gloss it over or sweep it under the rug, because that's when you see the real manifestations of anxiety and worry and concern in the youth when they're not being allowed to have those honest conversations. So the last thing that I'll talk about is schools. So you'll see off to the right, this is the most recent book. It's almost out. I think it might be out now. It's called At School. So it's a guide for supporting students. And this is for school personnel. Like this is for teachers, principals, school social workers, school staff. One of the things that we found in our data is that going back to school after the summer is particularly tough on youth, particularly those who are caregivers, because they're worried that all of that care they've been providing over the summer is just going to disappear once they go to school, particularly as ALS progresses. Has something changed? Is it a new diagnosis, perhaps? Are they moving to a new school? Maybe they have change in friends, and this is a real struggle for children, not only again in ALS, but any disorder. They really need kids who are going to be supportive and who are going to understand what they're going through. And so if any of you are engaged in schools or have children in school age or know of someone who works in schools, I just can't stress enough how important it is that school personnel understand the complexities of ALS and children, be willing to be there for that child, even flexibilities around, homework or tests or, just being patient. Oftentimes, and we talk about this in the book, there are many things that you can do, excusing the child to just go be in the nurse's office or the social work office for a little while if there's progression. And particularly school can be stressful when their family member is actively dying. It can be a real kind of jolt that their home and their family member is, in a progressive state of dying, and yet then they go to school, or maybe they aren't going to school and the school's wondering what's going on. So school is such an integral part of children's lives, and we don't always include that when we're thinking about their family member with illness. So again, that practice piece is very, very important when you're thinking about your kids, someone else's kids, maybe you work in schools, whatnot. So in closing, I feel like I've talked quite a bit, but in closing, I started with the words of the youth, and I'd really like to end with the words of the youth. Again, going back to, and I've really talked about a lot of information, but the most important thing is to hear them, to acknowledge the role that children play as caregivers and just participants in their families' lives, and think about ways that we all as professionals can develop interventions and supports for these kids. And this is really profound. In the end of the national survey that I did, we asked all the youth, is there anything else that you want to tell us? Just a really broad overview question. And this one youth had a lot to say. You know, he said, if I had to tell somebody that was my age, if they had a family member with ALS, I'd tell them you just have to be patient. You have to get used to new things, and you kind of just got to accept that that happened. And there's nothing you can do about it, but be there for them and for you. And I don't know that anything more profound could be said other than these words from this young boy, who's actually a young male who had a father with ALS. So that is my presentation. I think I'm in time, or within my time frame, maybe a little over. So I think we're open for questions now. Am I right?
Yes. We are open for questions. I have yes, well, bits outside the time frame, but I have an important question or remark. Your last, the quote of this boy, I mean, there's an astonishing loyalty in his quote. And that's also, and also my point, you talk about training, which I think is a very good idea. I really hadn't thought about it, to train them better so that they can provide help better. But my first reflex is to say, well, take away their burden. They shouldn't perform any tasks. I think that's naive. They probably do. They will always do more than you think. Always. Yeah. So how to address their loyalty? I mean, you can inform them, you can train them, but then you support their act of, providing help. Isn't their loyalty something to address? I understand they also can be happy because they help their parent. I mean, that gives something back, but of course.
Yeah, and that's a really, really good point. And I don't, I should make sure that I addressed that. Children often feel that push and pull. They struggle, they don't know what they're doing, they need all that help, but they feel a tremendous amount of, I like your word, loyalty, but they feel a huge positive boost, if you will. They feel good about themselves, that they're able to provide care, at the same time that they're really struggling with it. And so one of the reasons why that training and support piece, right? It's not just training. These kids are working with other peers. So they're developing friendships, they're getting support. But that's why it's so important, because they're feeling this like, oh, I'm really burdened, but I love my parent and I want to do what I can, but I'm really stressed out. So how can we kind of give them the tools, the peers and the support to really kind of connect those two things
and make the right choices for themselves? Yes.
Yeah.
Well, absolutely. I'm sorry, Melinda. I think we can talk about this for many more time. Lots of time. You have given us a lot to think about, and to and also a good boost to pay more attention to these kids. So thank you very much.
You're welcome. I'm so very sorry I went over. I apologize.
No. This was a very interesting talk and very important. So thank you very much.
Yes, absolutely.
Until next time, I hope.
Yes, thank you all so much.
Bye.
Bye-bye.